I'm gonna text Javier,
Hello,
Francisco.
hello everyone. Welcome to another virtual morning report. Uh, Unfortunately, our main discussant was not able to make it today. Uh, we are subbing in the CP Solvers members, Kirtan and I. I'm Youssef, one of the CP Solvers members and also a resident, PGYT resident. Uh, very grateful to be here. Welcome everyone. We're gonna have it more informal and open the floor for discussion. Anyone who wants to say their thoughts. They're very, very welcome. If you have your camera open, it will invite us more to invite you to speak, but it's completely up to you. Uh, I look forward to this case. Clara, do you want to introduce yourself? Tell us like why you're going into infectious disease, uh, and maybe one or two things you're grateful for.
Sure. Hi all, I'm Clara. I'm a second year PGY2 at Yale Primary Care. I'm very interested in infectious diseases and most likely going to do fellowship because um well, I think that thinking of infectious diseases and the way that it really thinks about like understanding the underlying etiology of illness and thinks about the whole person is really appealing to me. I also am really um and love to do work with underserved communities, immigrants, and refugees. That's a lot of where my passions clinically are. So I want to be able to bring the tools that are in infectious diseases to being like a primary care provider for marginalized communities that face these diseases a lot more often, and also considering some global health, public health work. Um, in terms of things I'm grateful for, I'm also very excited to present here. I'm currently in the Indian Health Service in Shiprock, New Mexico, and I'm really grateful for the opportunity to do this rotation. It's been a fantastic, almost 2.5 weeks now, and it's a really great experience and wonderful clinicians. So if anyone has a chance to rotate at a Indian Health site, I highly recommend it. It's well, one you will never regret it, and it may significantly change your career path. If I could, I would probably come back here for next rest of my life, but it's a little hard. It's a little bit farther away. But
Yeah, that's amazing, Clara. And I've come to find that the people interested in infectious disease are always the most caring and the smartest and the best people in the hospital. And I strongly believe that. Kirtan,
not
do
sure
you want
that
to introduce
applies yet.
yourself?
Yeah, I agree with you, Yusuf. Like whenever I'm dealing with a challenging case and I don't know how to do the chart biopsy, all I will do is find out the last ID note. And even if it's like day 5th or day 10th or day 50th, it doesn't matter. The note will be so comprehensive. They would have written each and every antibiotic, the precise date it was started, the date it was stopped, which cultures were positive, what were the susceptibilities. So if you need to know all the details, the ID chart is the way to go. So I appreciate the ID fellows in our life. And again, thanks, Clara, for bringing the case to us, taking the time out of your schedule. And guys, all of you who don't know that in the before we started this meeting, Clara told us that this case is kind of intricate and complex. So for all the ID lovers out there, please listen to this episode for sure. I'm sure we will learn a lot and hope that we could do the justice to the case. And hopefully collectively through the chat's efforts, we will be able to reach somewhere. So thanks for that.
Also on Francisco, who's our fellow ID fellow who really take care of the patient, may be joining us. I think he may have gotten caught up in clinic. Um, so I guess I'll just kick it off. Um, and I'm happy to answer questions. So we'll start with aliquot 1. Um, Sorry, my thing just disappeared. I have to close this. Okay. Um, so aliquot 1. Our patient was a 55-year-old woman. She was presenting to the emergency room with intractable headache. And before I know sometimes we dive straight into the chief complaint, but I'll give you a little bit of background on this intractable headache. She'd actually come to the emergency room 3 times in the last 5 days for a similar intractable headache. And each time she had received treatment with ketorolac and Reglan, and her symptoms had resolved. However, every time she was sent home and the medications like we wore off, her headache would return. So on this presentation, she woke up at 3 in the morning with a severe headache with associated abdominal pain, nausea, and vomiting. And then she also endorsed that she had some difficulty hearing while the headaches were flaring, as well as some blurry vision and unsteadiness with walking. And notably, she was given some triptans in the ED at discharge on the last representation, but she hadn't taken them because they hadn't had any good effect.
Thank you so much. Kirtan, if it's okay, I'm gonna take the first portion and then we can keep alternating if you want. In general, when I'm thinking about headache, my primary objective is to differentiate between a primary cause of a headache, like a migraine, a tension headache, or medication-related headache, or cluster headache, versus a secondary cause of headache. Uh, in general, there's a acronym called SNOOP, which has recently been popular. I've seen it in like a bunch of podcasts and on Twitter for red flag symptoms that make us think of secondary causes. So I think of systemic symptoms and as neurologic symptoms, sudden onset, older patients, and if it's progressive or positional. In general, the things that stand out to me so far is that the patient has had this headache for some time now, like 5 days, and has underwent multiple treatments to no resolution. Uh, and the other big red flag for me is the systemic symptoms, the abdominal pain, the vomiting, the unsteadiness, and the nausea, which makes me want to think of other secondary causes. Uh, I think it's appropriate initially to assume this is primary as that's much more common. But as the symptoms progress and as you see those red flag symptoms, I would want to think of secondary causes. Uh, Kirtan, what do you think?
No, I love that approach, Yusuf, that the first things first, that we have to identify if there are danger signs or not. And as you rightly mentioned, that since we have systemic symptoms, and as far as we know, this is the first time that patient is experiencing the headaches for last 5 days. So that itself makes you wonder if this is a secondary headache rather than the primary headache. And whenever I am trying to solve the headache, I first try to determine the anatomy, that how we would experience the headache, that what are the pain sensitive structures in your cranium which could make you have the headache. So for example, let's say if there is something in the parenchyma itself, then it's a little bit less likely that you will have the headache because it's the dura, it's the meninges, it's the blood vessels, venous sinuses, which are the pain sensitive structures, which means that whatever pathology is going on in the head, it has to impact either one of these structures in isolation or all of them together. So meninges, venous sinuses, blood vessels to cause the headaches. Now, once I have identified that maybe the problem is in one of these structures, I will try to go deep that which particular structures could be affected. So now we know that this patient has unsteadiness. So let's say that this unsteadiness actually represents something like ataxia. Then I start wondering if there is a problem with the frontal lobes, like bilateral frontal lobes, where there are the control centers of the gait, or the problem is with the cerebellum. Then once I hear that patient also has blurry vision, also has hearing changes, immediately I start to wonder that are we dealing with raised intracranial pressure in some way? Because nausea and vomiting could also point to raised intracranial pressure, although we cannot say that for sure. Maybe the patient has underlying gastrointestinal problem, either linked to the CNS problem or it is different altogether. But given the fact that patient has blurry vision, does make you wonder if the raised ICP is causing the headaches, it is causing the unsteadiness, and it is also causing the blurry vision. Now, regarding the hearing changes, that's also a little bit tricky because you start wondering if the problem is at the level of auditory nerves, the problem is at the level of bilateral middle ears, like the sinuses, or is it at the level of temporal lobes itself? And before we go into the individual etiologies later on, the one cool thing about neurology, which we have talked many times, is something known as the B syndromes, which stands for brain, eye, ear syndromes. So B syndrome is just a way to pull together all the weird autoimmune diseases, infectious diseases, which can affect your eyes, ears, and brain. So in our case, as of now, we have involvement of everything. We have eyes involved in some way, we have the ears involved in some way, and we have the brain involved in some way. So that makes us wonder that what if something is wrong with the basilar meninges? Because as you could imagine, all the cranial nerves eventually emanate from the skull base. So like auditory nerve, cochlear nerve, all of them will go through the foramina. And if there is something wrong with the basilar meninges, if there is an inflammatory process going on, you could imagine how you could encase the individual nerves, which could cause the blurring of the vision, hearing problems, and also the ataxia itself by virtue of raised ICP, because you will disrupt the CSF flow through the base of the skull. So these are the things I'm trying to figure out whether the problem is with the meninges or something else. So the next steps would be to know what are the exposures of this patient, what's the social history, is there any past medical history, is the patient immunocompromised, any travel history, and then you can go to the physical examination. So what do you think, Yusuf? Is that the right approach, or do you have any other pulse to share?
No, I love your approach. I can't wait to hear more. And I see excellent comments in the chat as well. I don't know, John, if you're able to unmute or not. If not, it's okay.
No, I'm able to. Thanks for the shout out. Yeah, just slowly picking away at step one studying right now, and it's just something that popped into my brain, and no pun intended. I think it's something to consider about, the parts of the brain that could really manifest and show the symptoms that you see in clinic in patient. So something always to keep in mind is, as Kirtan like so delightfully laid out, is the association with the structural components.
Yeah, you guys are doing incredibly. So I just want to say thank you, Kirtan, for that incredible master class on thinking about headache. I've literally never thought about it in terms of like what parts of your brain can sense pain. So that was phenomenal. And I really like you identified like the skull base and like the meninges as a potential area of concern because of the different symptoms. I'm not actually sure that even our own neurology team identified that as a potential area. All right. You guys ready for aliquot 2? Aliquot 2. So it's a little bit of past medical history. Overall, this patient was fairly healthy at baseline. She had a history of GERD, some hyperlipidemia, and prediabetes. And then her main issue was that she did have a history of chronic left-sided parietal and temporal headaches that began after she moved from Mexico to the United States about 6 years ago. She had followed with neurology for these headaches, which were presumed to be migraines. And they had been treated very effectively for a while with ibuprofen. However, she had stopped taking that because of some GI upset. She did have some prior imaging that was available to the team. She had an MRI 6 years ago that had maybe shown a question of a cyst, but otherwise been unremarkable. And then she had an ESR that was done in 2021 that was 31, so mildly elevated. And then she had another repeat MRI done about a year ago that showed mild prominence of the ventricles and slightly asymmetric prominence of the left lateral ventricle and chronic microvascular changes. So basically a little bit of enlarged ventricles, but otherwise within normal limits. A little bit of social history. She is originally from Peru. From Mexico, I apologize. And she lived with her daughter. She had notably taken care of her mother for many years, who had died of a prolonged lung disease. With thought maybe to be tuberculosis. The patient is a non-smoker and has no significant substance use. Her medications are basically some metformin, some omeprazole, and some Topamax for the headaches. She was also on the triptan, but didn't take it. She's not allergic to anything. Do you guys want her vitals and her physical exam, or do you want to talk more? I feel like you guys talked quite a bit about etiology already, but
I think we can go for vitals and physical exam, Clara.
sure. So, vital exam, she was afebrile. Her heart rates were in the 60s. Sitting well in room air. Blood pressure is 140s over 70s. This is all taken from like the H&P because I only saw her like after a couple of weeks. She was basically at that time looked slightly uncomfortable, but was otherwise well appearing. Her neuro exam was the thing we'll focus on, but basically her pulmonary exam, her heart, lung, her cardiac exam, and all of that extremity exam was all normal. Her neurologic exam, her eyes, there was no photophobia. She was able to like move her neck without any issue. Her sclera were anicteric, no injection. Her cranial nerves were all intact. There was no facial droop, no tongue deviation. all the extraocular movements were intact. Palate elevation was intact. Eyes were reactive. And then she had full strength in her extremities. All of her cerebellar signs were normal. Finger to nose, rapid hand movements. She was able to walk. And when walking, she was noted to have a slow and narrow base gait, but no shuffling. They did not do a Romberg at that time, but I think it was later done. It was negative. And she had normal sensations and normal reflexes throughout.
Yusuf, you wanna take a first stab at this?
Yeah. So this is a very rich, adequate. The things that I'm starting to extract from it is maybe the subacute nature of the presentation, uh, that maybe is getting to a tipping point, or it sounds like the history is maybe a little bit long-standing and now is getting a little bit more severe, which is tipping me towards that time frame. Uh, the imaging findings are definitely interesting. Uh, Cystic lesions have specific like differential on their own, and usually I would overlay that with the location of the patient. So usually, for example, Andrew mentioned in the chat neurocystocercosis. Neurocystocercosis is one of the most common causes of seizure worldwide, uh, other than primary epilepsy. But that usually is a calcified lesion that sometimes causes a seizure. But here we overlay that with mild prominence of the ventricles, with maybe some findings on exam. So one thing that I'm thinking of is, could this patient have chronic increased intracranial pressure, which may have led to ventriculomegaly? And I'm not sure if to layer in the cystic lesion as well. Like, do I have to think of the organism that causes both, or and I can think about them separately and then to join them together. Uh, and then I'm gonna leave the exam to you, Kirtan, and to see what you think.
Sure, sure. So thank you for giving us that epidemiological background of how you can link the cyst based on the origin of the country. Now, regarding the physical examination, the striking thing is that if there is a cerebellar problem, then we expect the patient to have ataxia, like Romberg sign sometimes can come up, but usually Romberg sign is not specific for cerebellum findings, but usually ataxia is, and it is wide based. So given the fact that we have narrow based ataxia, little bit imbalanced, does make us wonder that whether our initial hypothesis of ventricular dilation causing something wrong with the prefrontal cortex is causing this gait imbalance, because this is the gait which we see in people who have normal pressure hydrocephalus, that they have this magnetic gait, it is narrow base, they are not able to initiate the movements because the frontal lobes, they have this center. And this is one thing which I learned from attending the seminars on neurology, that this concept of normal pressure hydrocephalus is actually fake. Like many people don't believe it. People think that there is no such thing as normal pressure hydrocephalus. It's just hydrocephalus. Like any sort of hydrocephalus will cause gait imbalance if present for long enough. So at least from that perspective, given that we have some evidence of ventricular dilation and we have symptoms consistent with raised ICP, does make us wonder if these gait findings are actually due to raised ICP. Now, regarding the cause of raised ICP, so one easy way to look at the causes of ICP is whether it is communicating hydrocephalus or it is non-communicating hydrocephalus. So if it is communicating hydrocephalus, by that we mean that the lateral ventricles, third ventricles, all are working fine, and probably the defect is way distal. That's why all the ventricles will be like symmetrically dilated. And probably the problem is at the level of, let's say, arachnoid granulations or in the cerebral venous sinuses, kind of like what we see in people who have cryptococcus infection, because those cryptococci will be stuck in the arachnoid granulations and all the ventricles will be symmetrically dilated. But let's say if somebody has asymmetric dilation of one of the ventricles, like lateral or third, then we start wondering that maybe there is something wrong with the ventricles themselves. Like let's say there is a structure which is obstructing the flow of CSF from lateral ventricles to third ventricles, or from third ventricles to the fourth ventricle, and then through the subarachnoid spaces. So from that point of view, our patient has asymmetric ventricular dilatation. So that does make me wonder, what if this patient has non-communicating hydrocephalus. And then if I layer on the hypothesis of cyst, which was laid down by Yusuf, so Clara told us that this patient has been having headaches which were misdiagnosed as migraine. So this is also another pearl that whenever somebody has new onset of migraine in the older age, like let's say after the age of 50, it's same like asthma. People don't develop asthma and migraine in the older age generally. So whenever you see that, you have to question that, is this actually migraine or maybe something else? So in this case, as it turned out to be, it was not migraine, maybe it was this cyst which was doing something. Now, what this cyst could be, so as Yusuf said, neurocystic sarcosis is one of the diagnoses that we consider. The other possibilities could be like echinococcus, schistosomiasis, or amoebic diseases, but the time frame doesn't match well with all of those diseases as of now. Yusuf also told us that usually NCC present with multiple cysts, but now we found only one cyst. But sometimes this cyst can be cryptic. They can be occult. It is hard to localize them. So for example, cysts could be located in the subarachnoid space. They could be located in the ocular spaces. They can be hidden in the ventricles themselves, like intraventricular cysts. So sometimes you need advanced imaging to figure out that where exactly are the cysts. So with current findings, what should be the next step? So I think the next step would be to get the CSF, get the basic labs, but CSF is must so that we could associate the profile of the CSF features with the systemic features. So I think that's where we are heading next. And I think getting the basic labs would help us a lot. So what do you think, Yusuf? Is that the right way to go?
I think so. And in a prior infectious disease virtual morning report, the specialist said we take the infections that we were born around with us along with our genetics. So being from Peru and being from Mexico and makes me want to think, is that related to the current presentation? And given the subacute presentation, I would also want to think of that. I say this every time is that I always, whenever I'm trying to think of infections in a country, I literally look up CDC and I write the name of the country and see what pops up. And it gives you literally a list of infections that you can think of. And the things that pop into my mind are like things like Chagas, TB, and these are like the big two that I think of. But obviously, all other neurocystic sarcosis is also on the table. What do you think, Kirtan? Anybody wants to add anything?
Yeah, sure. I agree. All of those are fair games, and it's hard to pinpoint the organism at this point in time. That's why we need like more labs, more imaging, so that we could get further progress.
Perfect. You guys are doing great. Um, I think that this might be worth publishing this podcast actually, because I think you guys are doing such a great job. Okay. Moving on to the next alquat. Ask and you shall receive. So regarding the CBC and CMP, I didn't even write down what it was because they were totally normal. Because she'd come to the hospital 3 times already, they had gotten a CT head that was done the day prior to this most recent presentation, and that was basically read as like having no acute intracranial abnormality. So they did a CTA on her. The CTA showed that the lateral ventricles were dilated. Sorry. The lateral ventricles were dilated out of proportion to the sulcal prominence. There was also some bilateral superior semicircular canal dehiscence. And then they redemonstrated a partially calcified extraaxial mass within the left aspect of the subcellular cistern, potentially increased in size from the prior MRI. There was no mass effect, no intracranial hemorrhage, no large vessel occlusion or stenosis or aneurysm. And in all of that, because of the CTA, they got an MRI. The MRI showed that there was an unchanged, not larger, unchanged size of the 10 millimeter left extraaxial suprasellar peripherally enhancing lesion with some associated diffusion restriction and incomplete flare suppression, which I hope someone in this team is neurology based because I just looked at the picture. And then it also noted that there was leptomeningeal enhancement along the brainstem. Both of the MRI and the CTA were read as being possibly concerning for normal pressure hydrocephalus and intracranial hypertension. Would you like the LP now or later?
What do you think, Yusuf? I think we can discuss with these findings now. Yeah.
Yeah, we can start with this and then
Yeah.
we can go to the
And
other one.
Clara, I just before Yusuf shares his thought, I just wanted a clarifying question that when you said this patient had this extra axial, this sellar mass, so is what was it like outside the cranium, or you meant suprasellar, like inside the pituitary?
Um, I think it's supercellar. Sorry, I apologize. I misread it. Um,
Mhm.
supercellar. I
Okay,
misread the word.
that's
This
fine.
one.
So like it's not extra axial, correct?
No,
Right. And
I
you
have a
said it
picture.
was, oh yeah. I mean, if you think sharing picture will help, then I think that's great. We can also take a look at the picture.
I don't know if anyone here knows how to interpret MRIs very well. It's not my strong suit, but I can show a picture if you guys want.
Mhm.
Um, let's see. Do I have
Sarah,
access
do we
to
have an
share?
HIV screen or an HIV test?
HIV was negative. She's not immunocompromised. I don't know how to share this picture. Can I?
I think you should be able to share, Clara, since you are
No.
co-host.
Okay, one sec.
Mhm.
This
Yeah,
is the
we can see
picture.
it. We can see it. Hmm. And you
So it
said
was,
that it was
yeah,
the same size. It never expanded, right?
no.
Mhm. Perfect. Thank you. Thank you, Clara. Thanks for clarification.
Basically, it was read as like unchanged.
Sure. Yeah. So, Yusuf, my friend, what do you think that how
How do
should
I
we?
stop?
Yeah, that's good.
Yeah, I think in general, the classical teaching is we're supposed to get imaging before the lumbar puncture, and but there's no general teaching about what to do or how do you proceed with the lumbar puncture if there is like findings of the CT. But practically speaking, if there's no signs of impending herniation, the next step would be a lumbar puncture. In general, the things that I'm thinking of is that I see a mass-like lesion in the brain along with leptomeningeal enhancement. And I think that alone has like the would is what I would take to the specialist to discuss with them. I don't have a lot of like a very broad differential for that. I think the things that are we've commonly seen in the past are usually malignant etiologies, uh, things like TB, and then all the we say anything that TB can do, histo can do better. Histo and cryptococcus are like can also involve the leptomeninges. Uh, and I don't know, Kirtan, what would you add?
No, I agree with you, Yusuf, that the first thing we have to identify is whether this lesion which we are seeing in the suprasellar region and the leptomeningeal enhancement, are they linked? Like, is it the same pathology causing both of them, or is it different? So, for example, it is possible that suprasellar lesion is somehow affecting the dynamics of CSF circulation, and as a side effect of that, you are seeing this leptomeningeal enhancement as well. So, firstly, we need to identify that. And regarding that lesion in the suprasellar region, I agree with you that the infection etiologies that we have to consider are granulomatous infections. So tuberculosis is one of them, then non-tuberculous mycobacterial infections, all the endemic mycosis like histoplasmosis, blasto, coccidio, paracocci, and then some zoonotic infections like brucellosis is there, Burkholderia is there, and then based on the exposures like nocardia can do that, actinomycosis can do that. It's a long list, so we need the strong exposure history to pin down that which organisms could be there. So for example, we often say that things like tuberculoma, cryptococoma, all of them can cause cyst, and eventually that cyst can get calcified. So just having a cyst doesn't give us much information. We need the epidemiologic data to figure out what's going on, and we need the tissue sampling, all the culture results as well. Now, after having discussing the cyst part, let's focus on the leptomeningeal part. So as we were discussing in the first aliquot itself, that given these headaches, given these cranial nerve findings, probably we were dealing with something wrong with the basilar meninges or the brainstem. So now what are some of the organisms which have predisposition to affect the brainstem and the meninges surrounding the brainstem? So the classic teaching is that rhombencephalitis is the phenomenon, And the organisms which can cause rhomboencephalitis will also affect the basilar meninges. So all the granulomatous infections which we talked will do it. And some unique organisms which are known to cause this are Listeria. Like Listeria can cause rhomboencephalitis. Then Legionella can do it. HIV is known to do it. Herpes virus infections, Lyme can do it as well. Syphilis can also do it. Now, the time frame will differ in all of this. So, for example, Listeria rhomboencephalitis tends to be more fulminant. Same is true for HSV. So, given that our patient has had this for a while now, makes us less concerned for that, but doesn't rule it out completely. Other possibilities are that maybe this patient has parasitic infections. So there is something known as eosinophilic meningitis, and people who have eosinophilic meningitis tend to have these protracted headaches. And some of the common organisms to cause eosinophilic meningitis are the systemic helminths, like strongyloids can do it, neurocysticercosis can do it, even echinococcosis is known to do it, and then some unique organisms from the sea exposure, like angiostrongyloids or gnathostomiasis are known to cause this, and they can also affect the brainstem pretty badly. So the bottom line is that you need the CSF and you need to look at the differentials. Like if there are many eosinophils, then we will lean more towards the parasitic side, including neurocysticercosis. If it's more lymphocytic, then we will stick to the granulomatous part. If there is more hypoglycemia, then we will go to the endemic mycosis part. So each and every component of CSF analysis is going to be crucial in figuring out what's going on. And regarding this cellular lesion, I will definitely seek the help from our neuroradiologist that radiologically speaking, what does this cyst look like? Because the cyst of NCC is not the same as cryptococoma. It is not the same as, let's say, toxoplasmosis. Every cyst has its own features based on how it enhances on T1 and T2 flare sequences. So maybe I will ask the help from our radiologist that what should we do? And meanwhile, we can also send serologists from the blood of the basic infections that we were wondering, like neurocysticercosis or echinococcosis, the parasitic workup, helminthic workup, we can start that. And then we can do the fungal serologic workup. And then we can wait for the CSF work. So Yusuf, what do you think? That any other workup that you suggest?
No, I agree. I think this is a scenario where with the presence of a like a question mark mass and the leptomeningeal enhancement, this is the patient where I would want to speak to my neurosurgery colleagues. And this is where if we don't get an answer with lumbar puncture, the next step would be to get a sample of the tissue because this seems to be a acute on chronic process that has been going on, and we would want a diagnosis. So I think this would be I would ask the help for like my colleagues to go all the way with the tissue and maybe sample it. Uh, and it's very interesting that the patient does not have HIV and does not have any obvious immunosuppression because this is where I would usually more think of like the TBoma, Shagoma, Cryptococoma, and so on and so forth. But it's interesting this is without the immunocompromise or no obvious immunocompromise.
That's awesome.
Yeah, yeah, you can give us more data.
You guys are doing incredible. All right. And every time you guys speak, I'm like just getting a masterclass in clinical reasoning and thinking through complicated complaints. Okay. So our next aliquot here will be the CSF, as you hoped for. So in terms of the CSF, in the first tube, there was both of them were clear, tube 1 and tube 4. In the tube 1, there was 26 red cells, 110 nucleated cells. The differential on that was 70% lymphocytes, 28% monocytes, and 2% EOs. And then the tube 4 CSF was overall just the nucleated cells 163. And then it was the differential was slightly different. It was 52% lymphocytes, 33% monos, and 8% EOs with 3% basophils as well. The glucose in the CSF was low at 18, and then the protein was high at 165.8.
And Clara, do we have any details for opening pressure?
I think it was normal.
It was normal. Okay, perfect.
Yeah,
Thank you.
honestly, I didn't write it down, but I think it's because it was normal.
Perfect. So before I pass the mic to Yusuf, maybe I can do a preliminary analysis of the data we have. So as we were discussing that we need to look at the glucose, we need to look at the differential. So now we have CSF, which is normal opening pressure, lymphocytic pleocytosis, and hypoglycorrhea. So now what are the common ways in which we can deal with this? So maybe I will ask Yusuf to deal with the leukocytosis, like the lymphocytosis part, and probably I will deal with the hypoglycemia part. So this is something which we discussed probably like a month ago in one of the VMRs, that what are the infections and non-infectious conditions which can cause CSF hypoglycemia. So first thing to do is we have to find out the serum glucose. You want to make sure that compared to the serum glucose, the CSF glucose is low, because if your serum glucose is very high, then CSF glucose can be falsely high. And similarly, if your serum glucose is low, then CSF glucose can also be low. So you don't want to get into that trap. You need to get the serum glucose first and then analyze the CSF glucose. In this case, given that we have nothing in the past medical history, let's assume that the CSF glucose is true hypoglycemia. Now, regarding that, the common infections that we need to look for are the granulomatous infections, again, as we discussed. So starting with the mycobacterial infections, so like TB and NTM, then going into the fungi world, we think about three endemic mycosis, histoblascococcidio, and then one of the molds, which is cryptococci. Now, as Yusuf said, the cryptococci neoformans classically happens in people who are immunocompromised, but Cryptococcus gattii, the another form, can happen in people who are immunocompetent as well. So we need to keep that in mind. Once we move past these classic infections, we go to the acid-fast bacilli-like organisms. So nocardia will also cause low CSF glucose. Same is true for Brucella. Regarding the bacterial infections, so almost all the bacterial infections, like the classic gram-positive, gram-negative infections, will also cause low CSF glucose. And the amoebic infections, which we were discussing initially, like Naegleria or Balamuthia or Acanthamoeba, all three of them will also mimic this profile, and they can cause low CSF glucose. Now, the thing is that these last two organisms I mentioned, the amoebic organisms and the classic bacteria, they tend to cause neutrophilic pleocytosis. In our case, it is lymphocytic, but nevertheless, since I am discussing the low glucose part, I had to mention that they do cause the low glucose. And then non-infectious or conditions like lymphomas and solid tumors like carcinomatous meningitis, lymphomatous meningitis, all of them will also tend to cause low glucose. So there are so many things going on right now, but from the data we have so far, and given that we have lymphocytic pleocytosis, I am more worried about the granulomatous infections, acid-fast bacilli-like organisms, and some of the amoebic organisms. So Yusuf, how do you think we should integrate the lymphocytic pleocytosis in this framework?
Excellent interpretation, Kirtan. I think the lymphocytic phagocytosis is what we call a pivot point in this case. And whether it's lymphocytosis in the blood or in the CSF, it's usually the pivot point, which should tell you the very narrow differential. Uh, in general, when I think of lymphocytic phagocytosis in the CSF, I think of malignancies like lymphoma, for example, and sarcoidosis as well. I think of TB, viral meningitis, neurosyphilis, and neuroborreliosis. Uh, in general, layering on the tempo of subacute or chronic, I would, for example, make viral meningitis much less likely. Uh, I don't think you can rule out malignancy, sarcoid, or TB because they're all usually more chronic. Uh, neurosyphilis is syphilis is like the great mimicker, and it's definitely usually in my mind does not cause brain lesions, no pun intended, but uh, I would definitely test for it. And then like you mentioned, Kirtan, I really would want to think of the TB mimickers. Whenever I think of TB, I also think of all the endemic mycoses and cryptococcus. Uh, and Listeria is also the big mimicker in addition to syphilis. And anyone in the chat want to add something or any other thoughts?
So I think I agree with you, Yusuf, that the next steps would be to get the CSF microbiology panel. So we will need the blood, like the normal bacterial cultures, fungal cultures, acid-fast bacilli cultures, gram staining. We would need the India ink stain, like all the extensive workup which we do in anybody who has CNS problems. And the weird organisms are hard to pick up. Like, let's say you want to pick up herpes, you want to pick up mumps or like LCMV, all the viruses which can also cause hypoglycemia. You want to pick up Whipple's disease, let's say. Then you need PCR or like 16S ribosomal RNA sequencing. But those things are very advanced. I think that once we have the basic serum workup and the CSF workup for basic organisms, and if all of them are unrevealing, then we can go for this 16S ribosomal RNA for these organisms like Whipple's, which we cannot get normally. But so far, we are not suspecting those things. So maybe we can ask Clara if there were any serological workup done on the blood, which was remarkable, like normal CBC, LFTs, BMP, anything which can guide us.
Yeah, no, that's great. So like I said, most of the blood work was basically benign. And then all the cultures that you're asking for the CSF were sent. The bacterial cultures had no growth. The PC, they did a fungal culture, also was normal. They did TB cultures, and times all of those were cultured for 6 weeks and or no growth. AFB cultures, and then in addition to that, they sent off AFB PCR, and that was negative as well. So after that, because they were also thinking about just like you guys were thinking, like, was this a chronic infection? Was it a potentially a malignancy? I think in particular people were quite concerned about the leptomeningeal enhancement when all of this was negative thus far. So they did actually end up pan scanning her before during this admission, and all of that came back basically unremarkable. They syphilis was also sent, that was negative. I'm seeing the chat. They did in the pan scan, the only thing they noted was that there was maybe like some 6 millimeter nodules in her lungs. Otherwise everything was normal. And I'm just going to keep presenting as the case evolved, because actually the case took place over the course of 9 months. And so basically at this point, she'd been in the hospital for like over a couple of weeks. We didn't really have any answers for her. And so she got better with some Toradol. Her headaches got better. And so she was eventually just discharged home. Unfortunately for her, her headache came back and she represented less than like 2 to 3 weeks later. At which point all of this workup, the MRI and the CSF lumbar puncture were redone. The MRI was unchanged, just continue to demonstrate this question cyst and this leptomeningeal enhancement. And then the CSF was again basically exactly the same with this lymphocytic pleocytosis, with the low elevated protein and low glucose. So they sent everything again, essentially, as one does sometimes in a situation where you're thinking that maybe your sensitivity is not very high. But they added on a few other things. You guys had said you wanted syphilis. So I answer why don't we play a game of see what you guys already want, and I'll see if I can report it. So we said syphilis was negative, HIV was negative. You asked about Whipple's, that was negative. You mentioned Bartonella, that was negative. I think someone mentioned Lyme, that was negative. Fungitel was negative. They did 3 stool O&Ps. They did HIV, VZV, HSV on the CSF as well, and that was negative. The nocistocosis, that actually came back positive. So you got there before everyone else did. Coxy was negative, and the antibodies. Lyme was negative, and Q fever was negative. Nocistocosis was positive in the serum, and histo was negative, lepto was negative, and brucella was negative, and LCVM was negative. So you guys actually got to the answer before they did. This patient was treated presumptive. Oh, the thing that I didn't give you because no one asked for it was actually a quant gold, and that was positive ×2. So she was treated empirically for TB meningitis for 6 months. In that 2-month period, she had a reaction where she presented after the hospitalization with a left-sided facial weakness, which was considered to be a they thought that it was a reaction to the RIPE therapy and that it was basically a paradoxical reaction. So they treated her with prednisone and that improved. And then she was followed outpatient. You guys did ask Samantha neurocysticosis. Ironically, no one on our team asked for it. And so she actually got treated for the whole 6 months. At this time, she was following with ID and neuro, and people kept coming back and forth. And finally, people were like, why are headaches not getting any better? Or just like not really getting better because they're like chronically got better, then they chronically got worse, etc. And so somebody finally sent a neurocysticosis on the plasma to the CDC and then on the CSF to the NIH, and both of those were positive. And she ended up being treated with prednisone and albendazole and paraxequitol. But it was the reason nobody caught it was because it wasn't a classic case of neurocysticosis. It was actually completely extra parenchymal NCC neurocysticosis, meaning there was no involvement at all of her actual parenchyma. It was all just in the surrounding structures.
Perfect. Thank you so much, Clara, for giving us this rich case. And if we summarize the case, guys, remember the first record how we were discussing that's why sometimes anatomy and pathophysiology helps, because if the problem is in parenchyma, then you would expect like seizures or focal neurologic deficits. But as we discussed that since the headaches were the main complaint, we are more focused on the CSF, the dynamics, that how it is going. And then we talked about this vision changes and how we link the raised ICP. And this is actually a funny story. And since we have time, I can share this briefly, that the first time I discussed the case on VMR, it was like very early back in 2020s. And I remember probably this was my third or fourth case. And it was a neurology case with one of our dear team members, Sukriti. And it was a case of intraventricular neurocysticercosis, which presented as hydrocephalus. And then the same year, I was applying for residency. And then you apply for, like when you interview at different programs, they have their own morning reports on the day when you are applying. So I remember I applied in one of the Texas, probably like it was Baylor. And the Baylor's morning report was on subarachnoid neurocysticercosis. And that day I again texted Sukriti and everybody that, hey guys, we discussed this and now this came again. And then again today, we came across this finding. And it's a funny story. When I was in the neurology rotations, we discussed something known as Tumarkin attacks. So it's like TUMARKIN. So Tumarkin attacks happens in people who have Meniere's disease. So what happens that people with Meniere's disease sometimes suddenly fall without losing consciousness. So like they will be walking and they will fall. So it looks like syncope, but just the difference is that there is no loss of consciousness. And the pathogenesis hinges on the fact that there is sudden rise in the intracranial pressure, either at the level of otoliths or inside the CSF. And actually same theme happens with NCC, that whenever people have intraventricular neurocysticercosis, because of the ball valve effect, this cyst can be bumping around, and depending on your position, it can block the circulation at one particular time. It will raise the pressure so much that it will cause blurring of the vision, all these changes. You could fall, you could have syncope as well. So we have seen people having recurrent syncopes just because of intraventricular neurocysticercosis. So that was the teaching which I learned from our neurology rotation, that whenever people have headaches or people have this syncope, then always think about neurocysticercosis. And since Clara told us there was this cyst which was calcified and whatnot, so that made our suspicion even higher. So thank you for that case, Clara. And Yusuf, what do you think? What are your reflections?
I really want to thank you for bringing this case. It's really, really fascinating. How was it caring for this patient? Did they do better after treatment?
Yeah, she got great. So I actually only cared for in the big middle section where we thought we were treating her for TB meningitis. And it's interesting because I think when you're like in the middle of a situation and you just inherit a patient, you're just like, oh, this is what I was like 2 weeks into intern year. And I did not think even to like, this was patient 1 of 10. I didn't have the chance to even think through the differential. I was like, we're treating her for TB meningitis, which I thought was pretty darn cool to begin with. And so it was interesting to go read back like months later and just follow her and like see what happened. And I think what one of the big lesson points, I think, for the teams, for the ID and for the neuro teams was two. One, I found a note from the very beginning, like years beforehand, from her PCP, who was like a resident who had seen the cyst, noted, and had put like differential question mark NCC. And it was never like pursued further because this patient was basically like otherwise asymptomatic and being treated well and had a neurology team following her. The neurology team kind of ignored this And so one thing that came up, I think, a lot in learning, thinking more about the case, was that one, I think it takes there's a ton to be said about like when you actually think that something's going to be odd, having a conversation about it. Like, I think the reason we all were like able to think through all of this partly is because we're in a setting where we're being primed to think about weird things. But when you're actually like in the hospital taking care of patients, and you guys all know this, like half the time you're just like basically treating what you presume to be the diagnosis. Often like the differentials for things have already been discussed on prior rounds, and you're not sitting down and having those conversations again. And so there was a lot of oh God, what's the word? By all the teams involved, there was a lot of, oh God, what
Diagnostic momentum.
Yeah, lack of diagnostic momentum, and also now I'm like forgetting the word when you hold on to something.
Anchoring.
Anchoring. There was a ton of anchoring. So there was a ton of anchoring on all sides. So when she had a diagnosed with TB meningitis for 6 months before, without much improvement, before anyone even thought to send the neurocysticosis evaluation. And so I think that that's something to be really learned, is that sometimes there are cases where it makes sense to take a moment and step back and rethink it, and not fall into the deep anchoring. Because if you read through her chart, it was like TB meningitis, TB meningitis, I mean, she was doing dot therapy. Like, it would be very, 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 very easy to not think twice about that diagnosis once it was labeled to her. So I really appreciate you guys did a great job. You caught that if we had presented this case to you guys earlier, 9 months prior into the second day of the case, you probably would have diagnosed her. And that would have been 6 months earlier than everyone else did.
No, so in general, the med ed literature says that if we tell people not to anchor, it does not alone help them not to anchor. But the biggest cure for that is more knowledge. And because the eyes can't see what the brain doesn't know. And by you teaching us today about this case, I think everyone listening and everyone watching will think twice before passing on a patient with a brain cyst. So I thank you again. Thank you everyone for joining. I hope you have a wonderful day.
You too, guys. Also, I did want to just present a little teaching. Just,
Oh, yes, please.
neurocysticosis, only like 30% of people have headaches, even across the board with extra parenchymal neurocysticosis. Only 30%. It's not a very common presentation actually for neurocysticosis, like you guys are saying. And what I think was interesting was that to do the CSF findings. I was reading a retrospective review that showed that the CSF findings in the extraparenchymal neurocysticosis have much higher protein levels in the 150s to 200s, versus like if you do a normal CSF with neurocysticosis that's not extraparenchymal, it'll usually be like 45 or 50. So that's like just a little tidbit. I can link the paper I was just reading. So I thought that was really interesting as well. Because, and interesting, like seizures are much more common in the parenchymal type, as you guys were saying as well. But intracranial hypertension is much, much higher rates in extraparenchymal, which she didn't actually have. She had imaging findings of it, but there wasn't actually any like evidence. Like her gait improved after her headache resolved, for example. All of those acute findings that we were attributing to increased ICP resolved with resolution of her, like symptomatic resolution of her headaches. Which I thought was also very interesting. But yeah, that was great. You guys did an amazing job. Kirtan, I wish I had your brain. Like, damn. That's really cool. And Youssef, you guys just did a great team. So thank you so much for letting me present this case, and I hope y'all enjoy it. We did not need an expert reviewer. You guys were our experts.
Thank you. Thank you so much, Clara. And just one final question I wanted to ask Clara, that when this patient came in the clinic, let's say in the follow-up months and months later, she was totally fine, right? No symptoms, everything turned out well.
Oh yeah, she did great. She's totally fine now.
Yeah, that's good. That's good to know. If the patient does well, that's the success for doctors. So I love that. Thank you so much, Clara.